And we're back on this Saturday morning Sports Medicine Weekly. Steve Kashul, Dr. Brian Cole, thanks so much for being with us. Our website is sportsmedicineweekly.com. And a reminder, net proceeds from our show, Sports Medicine Weekly, go to support orthopedic research at Rush through the liveactivenow.org fund. Our producer, Shane Reardon, our coordinating producer, as always, Tracy Toro. Time now for the staple of our show. It's our Ask the Doctor segment, giving our listeners the opportunity to have Dr. Cole address their specific sports injury issues. Very easy to get involved, folks. Just go to our website, sportsmedicineweekly.com. On the homepage of our website, you can look at the picture of Dr. Cole and yours truly. Click on the link underneath that picture, and you can submit a question for the Ask the Doctor segment. Are you ready to ask the doc, or are you ready to respond to the doctor's, the listeners' questions? I'll get it right. Here we go.
Right. See if you can stump me.
Here we go. Question number one this week, Doc. I got a cortisone injection for osteoarthritis in my knee. Then the relief lasted for a few months. Dr. Cole, how long do these injections normally last, and how often can I get them?
Very common thing that we do to treat the symptoms of arthritis is to use cortisone. We use it in lots of joints, the knee being the most common because that's the joint that presents most frequently with arthritis. And what I tell patients is I say, look, if you've never had one before, here's what you need to expect. It may provide no difference, or I've seen people get a very prolonged period of time in terms of symptom relief. Sometimes I've seen a year or more. So I consider cortisone injections for arthritis to be very, very safe. Our basic rules of thumb are we like to do no more than 3, maximum 4 a year. And what's really fascinating is the literature and our experience doesn't necessarily show that it can cause damage, but there's a convenience aspect and so forth, and rarely do we see any complications with the cortisone injections. But we say if you get about 3 or 4 months, then you can repeat it. But if you don't get satisfactory relief for at least 3 months, then we often don't repeat it. So I can't always tell people how long it will last. Truly, if they have lower degree of arthritis, then they're more likely to respond. But I've seen it all across the board between getting no response to a terrific response that lasts longer than a year. And in general, we say no more than 3, max 4 injections into the knee per year.
Dr. Cole, it's not a masking agent, right? I mean, does it take care of the pain as a painkiller, or is there an ingredient there that helps repair what you're trying to fix?
Yeah, it's a great question, because I have patients say, look, I don't want an injection, I want to feel the pain. But the reality is that 60 million people run around with arthritis in this country, and many of them don't even know they have it because many of them never get symptoms. So we don't have much literature that tells us, or my experience that tells us, that if we allow people to remain active with known arthritis, that they're going to cause further damage, right? So then you say, well, what's the difference between someone who has symptoms and someone who has no symptoms, but they both have arthritis? We don't even know that answer. So the reality is that we tell people that we want to modify your symptoms so you can do more without symptoms. And we're not looking really for pain to give you an inhibitory response. It really doesn't, in my opinion, work like that. So if I can make you feel better, I don't have to cure you of arthritis. And certainly cortisone or all these other fancy injections we have don't necessarily rewind the clock or recreate cartilage, but it's all about modifying symptoms to a satisfactory level for a patient. And that's what something like cortisone or some other things can do. So we're really treating the pain and dysfunction that patients complain of, not the x-rays or the MRIs that show arthritis. Does that make sense?
Yeah, but I've also had the cortisone injection where they say, I can't do any physical therapy, right?
Right.
So you give me a cortisone injection. All of a sudden, I'm able to move and exercise.
Yeah, I'm okay with that.
That joint, right?
I'm okay with that.
Better than if I didn't have the cortisone injection. Right?
Right. There's something about your condition that became symptomatic, and cortisone can, in some instances, can be an off switch. And it doesn't change anything structurally, but it works by reducing inflammation. Maybe it inhibits the pain pathway. It reduces some of those inflammatory proteins that our bodies produce in an abnormal situation like arthritis, and it makes people feel better. Same thing with taking an anti-inflammatory that's prescribed, like Motrin or Naprosyn or Celebrex or Mobic. Those are all drugs that we commonly prescribe that are anti-inflammatories and treat arthritis. It's been well established that these medicines can treat arthritis and make people feel better, but it doesn't do anything to the disease state. So I always have to, I have to have this conversation not infrequently with patients about, it's not a Band-Aid. The goal is to make you feel better so you can do more with less or no discomfort.
Okay, I got one more for you before
Sure.
we say goodbye in this section of our Sports Medicine Weekly show. Dr. Cole, I've heard a few friends talk about gel injections for knee pain. What exactly is this injection, and what is it indicated for?
So gel injections are in the sort of lineage of treatment for arthritis, and the only real indications that we have now are for knee arthritis. We use it occasionally off-label in other joints like the hip or the shoulder, but the place that it's indicated for is truly the knee. And hyaluronic acid is the other name. That's the chemical name for these gel injections. And there's at least 8 to 10 of them that are available. Sometimes it's a single shot, all the way up to 5 injections given a week apart. And it's essentially a sugar that's linked together. It's been around for a very long time. And hyaluronic acid is really part of the building blocks of cartilage. It's basically a component of what we call proteoglycans, which is one of the chemical makeup, chemical components of cartilage. Now, I can tell you that just because we give an injection doesn't mean that we make cartilage better, but there's actually good literature and statistical studies that show that it can make you feel better and reduce the symptoms of arthritis. And I've had patients get 4 to 6 months relief with these gel injections. So it was actually approved by the FDA as what we call a device, but it really works like almost a biologic from a chemical perspective when we inject it in the joint. So we still use it very frequently to treat the symptoms of arthritis. My own personal algorithm is we use it after we try cortisone, and if that cortisone works, we keep doing it. If it stops working, then we often move on to the gel injections or the hyaluronic acid injections to treat the symptoms of arthritis.
Nice to have another option, right?
Yep, absolutely.
All right, we're out of time. Great job, Dr. Brian Cole. Many thanks to our producer. As always, he is Shane Reardon, our coordinating producer, Tracy Torrell. Also want to thank David Cole for managing our website, which is sportsmedicineweekly.com, and also to Samantha Smith for all her help from Midwest Orthopedics at Rush. For Dr. Brian Cole, my name is Steve Kashul saying so long. Thanks so much for listening to Sports Medicine Weekly here on The Score. Up next on The Score, Early Odds with Joe Ostrowski. We'll be back next Saturday, 8 a.m. with a brand new edition of Sports Medicine Weekly. It's been my pleasure. Dr. Cole, have a great week. And you're listening to Sports Medicine Weekly only on
670 The Score.